During the meeting, I'm going to present data on supportive care, and we have to be aware that optimal supportive care reduces mortality in several instances and certainly improves quality of life of our patients, and certainly reduces costs if supportive care is given in a professional way. So I'm talking about some new developments. What is new in prophylaxis, in thromboprophylaxis? Now we all know that the direct anticoagulants, novel anticoagulants, the direct ones, are used heavily in several diseases, and there are now recent studies have been published showing that they are safe in cancer patients and effective. There is retrospective data in myeloma as well that you can use apixaban 2.5 milligrams 2 times a day, and when you do this in your myeloma patients during first-line treatment, you reduce the risk for thromboembolic complications. Actually, this was a small study, 70 patients, and they didn't observe, after short observation, any thromboembolic event, but they had 2 arteriovascular events. So, in other words, the novel direct anticoagulants may be used in this disease. Other question pops up when you have to treat a patient with severe hypercalcemia, even particularly those patients with renal impairment, where the use of bisphosphonates is difficult because they are not approved for patients with low renal function, GFR below 30. So you may think about using denosumab, and there are data available showing that denosumab is very effective in reducing hypercalcemia, even in patients who are resistant or cannot be treated with bisphosphonates. So this is, I think, an interesting finding. Of course, there is a very beautiful prospective randomized study which has been reported at the previous ASH meeting, randomizing almost 1,000 patients to either levofloxacin prophylaxis, antibiotic prophylaxis for 3 months, or control. And those patients who were on prophylaxis had significantly reduced rates of infection and even better progression-free survival. So that is, in my opinion, not a plain bourgeois to use antibiotic prophylaxis in every patient, but you should select your patients carefully. Those are patients, in my opinion, which should be treated, which have a history of prior increased rates of infection, or elderly, frail patients which are started on therapy, or patients which have other risk factors for developing infections. So the question is, should you use levofloxacin or Bactrim or amoxicillin? This question cannot be clearly answered. We prefer Bactrim analogs for prophylaxis in our patients who have a high risk for developing infections during treatment, particularly during first-line treatment. Another important side effect is cardiotoxicity by myeloma drugs, and the cardiotoxic potential varies from drug to drug, and there's more cardiotoxicity with carfilzomib when carfilzomib is used in combination in elderly patients with multimorbidity. So I talk about what precautions can you take and what needs to be done if there is a cardiotoxic event. First of all, and most importantly, patients should not be treated if they come in with hypertension. So their hypertension should be controlled. They shouldn't have NYHA 3 or 4, so significant and severe heart disease. But otherwise, you can safely treat those patients. If there's a complication, maybe an increase in blood pressure or dyspnea, wait until the complications normalize. If the patient is well again, you can consider restarting carfilzomib. There are only a few patients where you want to discontinue. So this is important to keep patients on carfilzomib because it may be a very important drug for them. So one shouldn't discontinue early without any good reason. Another issue is, of course, a very rare complication of myeloma therapy. It's called thrombotic thrombocytopenic microangiopathy. This is an emergency situation. So patients are treated with a certain drug like bortezomib or carfilzomib, and they may do well, and suddenly if they have probably another complication triggering this TMA, like an infection, and then you give in addition, you don't put much weight on this problem, or you oversee it, and then you treat your patient with carfilzomib, it may happen that the patient develops this complication. And in the old days, people tried to use plasma exchange, but plasma exchange is not working in those patients. There is a new treatment available called eculizumab, which is used for paroxysmal nocturnal hemoglobinuria, and this is working because it interacts with the complement system, and so it may rescue your patients. So we should think about this. So I think with appropriate supportive care, you not only improve quality of life for your patients, but you may save lives, you reduce mortality, and certainly you reduce costs which may ensue due to complications of the disease or of treatment.